Yeah. I got them today.
Yeah.
No, purple. Mine is very big today. Like almost what I have, but yeah. And it's calm. Like, I'm not going to spend all day in calm. Yes, yeah. Brad especially.
Yeah.
What's that?
Which one?
1733. Okay, sorry about that.
It happens.
Well, small class today. Good morning.
Good morning. Good morning.
I did a couple of things over the weekend, posted a couple of simplified slide sets, one for the acid base and the other for the glomerular diseases. So focus on those for the exam. I did not take down the other slides because the Zoom coincides, it goes with the other slide set. But if you're just looking at slides for the exam, then look at the simplified versions for the acid base and for the glomerular diseases. Okay. I think they're both posted under, the class for appropriate class. So we are going to talk about airway structure and function today, but I did decide that we were going to finish the glomerular disease off because it's some of the slides that we didn't get through are some of the more important ones. So who discovered oxygen? This guy, Carl Wilhelm Scheele, or Swedish chemist, Joseph Priestley, English chemist. The French also tried to get in there as well with Lavoisier, who was a French chemist, but he sort of came a bit later. But we'll get to the real truth a bit later. Let's finish off the glomerulonephritis. And when you think about it, we did chronic kidney disease and diabetic nephropathy. That starts off with damage to the glomerulus. That is a glomerulonephritis. This is sort of an extension of that, but certainly chronic kidney disease and diabetic nephropathy come under this heading of glomerulonephritis as well. And it starts off with glomerular damage. And obviously, with diabetic nephropathy, it's the glucose that causes the hyperglycemia that causes the damage. Other things, immune complexes are very common, depositing in the glomerulus and causing damage to the glomerular structure. Various drugs can cause it as well. Other diseases, including diabetes, and genetic changes to the podocytes, the foot processes, the mesangial cells, can all lead to some initial damage to the glomerulus. And the important thing that happens is that you get increased filtration of proteins. And this increased filtration of proteins is the initiating factor for the inflammatory response, the downstream immune response. So filtration of proteins is sort of the initiator of a lot of the changes that happen after the initial glomerular damage. So it's an inflammatory cascade, damage to the tubules. The mechanism is essentially the same for all of these different conditions. So see chronic kidney disease for the mechanism of the downstream inflammatory response. Characteristics of glomerulonephritis, and I've changed this slide a little bit because some of the bullets are on the previous slide. The cell proliferation. One of the main problems in these conditions is that you get fibrosis of the interstitium. So there's sclerosis, fibrosis, and then cell death as well. There's upregulation of some of the clotting factors, so you get hypercoagulability and thrombi, can cause intravenous vascular damage. And there's a decrease in overall glomerular filtration rate, even though you're filtering more protein. And this leads to salt and water retention. This leads to edema, hypertension. So these are a couple of the major signs and symptoms that you see in these conditions. And in the urine, lots of protein, and in some of the conditions, hematuria. Not in all of them, but in some of them. You can get protein in the urine without having disease. So it's called benign proteinuria. It occurs as a result of not just exercise, but excessive exercise, very heavy exercise, certain fevers, obesity, stress. Interestingly, sleep apnea can be associated with protein in the urine, and congestive heart failure. So there's really no changes in renal function, but there is something happening in the glomerulus that leads to this increased filtration of proteins in these other conditions where there's really no renal problem. The other condition you'll come across is called nephrotic syndrome. So talked about nephritis. So that's an inflammation, and there is an inflammatory cascade that causes damage to the tubules. There's a condition where you see capillary damage, you get protein filtration, but there's no inflammatory response, and they call this nephrotic syndrome. And you will see it referred to in the literature. I'm not saying it's real common, but it's not that rare, and it can be caused by various factors. Clinical presentation, there's glomerular capillary damage, increased protein in the urine, and this is not just minor amounts of protein in the urine, but fairly substantial amounts in the urine, over 3.5 grams a day. And there's it's called you get lots of albuminuria. One of the consequences of this heavy protein loss is that the liver that synthesizes most of the proteins in the body, including albumin, can't keep up. And so you don't get enough protein produced to make up for what's being lost. You get a hypoalbuminemia, so you get low albumin in the serum. There's decreased renal function, mentioned that, so there's edema, salt water retention, edema, hypertension. There's hyperlipidemia, there's upregulation of the synthesis of the lipoproteins by the liver, and increased lipids in the blood. So there's also fat seen in the urine because of the hyperlipidemia. Again, hypercoagulation, maybe some hematuria in nephrotic syndrome, but usually minimal, nowhere near as much as you see when there's an inflammatory response. So the main thing here is the protein rather than... Was that important?
No, it's last night. I didn't put out the video, so I just opened it up.
Okay. Okay. Can't you just turn it off?
I know, I can't log in.
Okay. Boy. Just turn the speakers off. I always turn the speakers off on my computer. I can't stand the sound and things like that. And anyway, okay. Nephrotic syndrome, pathology, pathogenesis, minimal cellular filtration of the glomerulus. So no inflammatory response here. There are some conditions where there are the same as the glomerulonephritis. You get immune complexes deposited, but they have a different effect. They do not induce the inflammatory response. There is something that is called minimal change disease, and this is part of nephrotic syndrome. Proteinuria is really the only abnormality. I don't know where the minimal came in. I took that out. If you look, there are structural changes to the podocytes and the foot processes, But really, that's the only characteristic that's seen in this, and you just get heavy protein filtration because of this structural change. What are the causes of this? It's usually secondary. I mean, it can morph into glomerulonephritis. So the early stages of IgA nephropathy, before the damage starts, before the inflammation starts. Early diabetic nephropathy, where you're starting to get, you've got the hyperfiltration and you're starting to get some damage and you're starting to filter the proteins, but you haven't got the inflammatory cascade yet. And then, post-infections, you can get these immune complexes deposited. If it's severe, then you get the inflammation. If it's less severe, you may not. So secondary to lots of other conditions, it can be it can be primary, and the major cause of the primary is this minimal change disease, where there are some structural changes to the podocytes. In this condition, you see a much more severe proteinuria, and you're losing more than 10, defined as more than 10 grams a day of protein in this condition. Okay. What's the problem with loss of proteins in nephrotic syndrome? If you lose too much protein from the plasma, you decrease the plasma oncotic pressure. So you get a very watery type plasma in terms of when you look at it for proteins. So you start losing water out of the vascular compartment. It leads to decreasing the intravascular volume. So you decrease the blood volume. This can lead to shock, and if you get shocked, then you can get hypoperfusion of the kidney, and that can lead into acute kidney injury. So you just amplify the problems that you get in the kidney. And because you're losing the fluid out of the vascular compartment, it's going into the interstitium, so you get interstitial edema. This decreased perfusion of the kidney, well, it upregulates the systems that we've talked about, upregulates the renin-angiotensin system. It's trying to increase sodium and water reabsorption. Activates low blood pressure, activates the sympathetic nervous system, again, to try and increase kidney function to upregulate sodium and water reabsorption. Secretion of vasopressin, increase water reabsorption. And again, there's this increased lipoprotein synthesis by the liver, and you get a hyperlipidemia. The liver, we'll talk about this later. The liver only produces two types of lipoproteins. It produces the very low density lipoproteins, and it produces the high density lipoproteins. It does not synthesize the low density lipoproteins. They get formed in the plasma. So very low density lipoproteins synthesized by the liver, released into the plasma. They get metabolized to the intermediate density and then to the low density lipoproteins in the plasma. And the HDLs also get synthesized by the liver. Okay. You do lose proteins other than albumin. This has other consequences. There's lots of immunoglobulins, including IgG. This increases the risk of infections because you get, you do not deal with the bacteria, don't opsonize the bacteria the same way. You get hypercoagulability because there's a lot of antithrombin 3, protein CNS, and there's increased factors 5 and 8 and fibrinogen. So upregulation of the coagulation system. We talked about this before. The final activation step for vitamin D is in the kidney. So you're losing renal function, you lose the ability to activate vitamin D. This leads to vitamin D deficiency, bone loss, and fractures. Loss of thyroxine binding protein, also vitamin D binding protein, but thyroxine binding protein as well. And so you carry less T4 thyroxine in the serum. This leads to hypothyroidism. And this is just a summary compare and contrast of nephritis versus nephrosis. Any questions? Okay. Okay, we really are done with the liver now. Kidney. Liver next semester. Okay. So let's come back to these guys. Have you ever heard of these guys?
Unless he makes Swedish fish, I don't think.
What's that?
Unless he makes Swedish fish, I don't think so.
No, okay. Not of Joseph Priestley. I thought Priestley was pretty famous, but maybe it's because he's English. So who discovered oxygen? And 1804, not 1904. And as I say, there's Lavoisier, who came along a little later. He was French, but I don't think he really claims that he discovered oxygen. But he certainly showed, how it was, produced in combustion. Maybe it was neither of these guys, because if you look up history of oxygen, you'll find Scheele, Priestley, Lavoisier. You won't see this guy, Michael Sendivogius. He was a Polish alchemist, and he did a lot of work with potassium nitrate, saltpeter, and he called it the compound of life, because he found that if you heat potassium nitrate, it gives off a substance that helps things live, oxygen. So he did this a couple of hundred years before these other guys came along. He didn't call it oxygen. Lavoisier was the one that called it oxygen, but he certainly isolated it and showed that it had, the effect of being able to sustain life. So he isolated oxygen before the other guys did. So did he discover it? Oh, I would have said so. Okay. So what we're going to talk about for the respiratory classes, this first class is going to be a little bit of review, because we covered it in 371. We're going to talk about some of the lung structure function, talk about the volumes and the lung function testing. We've always talked about it in this class. 371 was an addition this year, because that course has changed from what it was previously. So we're going to talk about the structure, and how it breaks down in various airway diseases. We'll talk about how the gas, oxygen, CO2, is delivered or removed, how it's transported in the blood, chemical neural control of ventilation, and then how these all breakdown in these conditions play into the major airway diseases. Talk about asthma, COPD, cystic fibrosis, pulmonary fibrosis. If we have time, we'll talk about lung cancer. When we talk about the diseases, we'll talk about the pathology and the mechanisms that develop that. So the pathophysiology, signs and symptoms, diagnosis, and I'll put in some slides on treatments, but there will be no questions on treatments on the exam. So what does the airway do? Well, its goal is to deliver oxygen to the body and to remove CO2. It also helps balance pH in conjunction with the kidney. As I say, that equation that I keep putting up, the kidney works on the hydrogen ions bicarbonate side, the lungs work on the CO2 water side. The problem with the airways is that it's an opening to the outside world. And so when you breathe in all of the stuff that is in the outside air. Oxygen that you want, but also there's other stuff as well. Lots of particles, gases, irritants. And there are mechanisms to sort of negate these problematic things that you breathe in. The air that you breathe in is typically not body temperature and not always completely humidified. So one of the things that the nose and the upper airways do is to warm and humidify the inspired air. They try and prevent particles from entering the lungs, not always successful. particles do get in. So they've also got mechanisms for the particles that do get in for trying to neutralize them and then get rid of them. How do they do that? There's inflammatory and immunologic responses in the airways. There's resident immunologic cells, resident inflammatory cells here, mucociliary system, and coughing. So the airways are lined with mucus. They trap particles, they can neutralize particles, and there's a ciliary system that gets rid of the mucus out of the airways. And when that fails, when the mucus becomes too much, then you have coughing to get the particles and the mucus out of the airways. And these systems help prevent diseases, but they can also become dysfunctional and play into the disease that we'll talk about as well. Other things that we're not really going to talk about, the airways have metabolic functions, olfaction, and also vocal. We're not going to talk about the larynx and the nasopharynx, but we will talk about the nose. Because we're going to talk about, hopefully, when we talk about asthma, we can tie in allergic rhinitis as well. So the nose is central to allergic rhinitis. So a couple of pictures through the nose. This is, cutting it this way, and then this is a frontal cut. And the airway passages in the nose are fairly small, and over 50% of the resistance to airflow in the airways is in the nose. So that means that there is fairly intimate contact between the walls of the nose and the air that's coming in. So it helps warm it and it helps humidify it. The surface area is increased by these pieces that stick out from the sides of the nose. You can see them easier here. So this is the septum. And so this pink area is the nasal passage. And there are these protuberances on the sides coming into the nose. These are called turbinates. And the structure of these is exactly the same as the septum and the other part of the nasal wall. The goal of these turbinates is just to increase the surface area. So it increases the contact between the inspired air and the moist surface, the warm surface of the nose to help warm and humidify it. The anatomy of the if you take a section through the wall and you look at the mucosa and the submucosal tissue, it looks very similar to what we'll talk about for the lower airways, except there's one difference here. It has blood sinusoids that are erectile. Okay, so there are two erectile tissues in the body. One is the genitalia and the other is the nose. And these sinusoids can expand, they can constrict, and when they expand, that's when you get nasal congestion, because they swell the tissue and block the passageways. So these sinusoids in these turbinates and in the septum are erectile. They can be constricted by alpha adrenergic receptors, so sympathetic input can constrict these, and they can be dilated by parasympathetic. And the dilation, and they can also be dilated by, in colds and things like that. The dilation is what causes the nasal congestion. Nasal decongestants are alpha sympathomimetics. So they are alpha adrenergic receptor stimulants, and they can constrict these vessels and decrease the congestion. So used to be, what was it? Used to be pseudoephedrine. I don't think you can get pseudoephedrine now, can you? It's probably a banned substance. So pseudoephedrine, I think, was the alpha adrenergic agonist that was commonly used. Sudafed You ever heard of Sudafed?
Oh, yeah.
Okay,
You
that
can
was
still get that.
okay, but I don't think it's pseudoephedrine anymore, is it?
No.
Pseudoephedrine, I think, can be used to make amphetamines.
Well,
Yeah. So pseudoephedrine used to be the oral drug. The topical has usually been it's oxymetazoline, and this is an alpha-1 adrenergic. It's much more potent. So to me, if you're going to take a decongestant, take a topical. It works. I think pseudoephedrine now has been replaced by phenylephrine. Phenylephrine works topically, but taking it orally, it gets broken down, and I think very little gets into the systemic circulation. So as an oral decongestant, I think phenylephrine is pretty worthless. But I think that's all you can get now because pseudoephedrine has been taken off the market. Okay, just an aside there. Okay. The nose obviously can trap large particles. They get deposited in the mucus, and the mucociliary system moves them backwards to the back of the throat, where they can be swallowed. Okay. The other thing, oh yes, turbinate, not turbinates. Okay, I changed the slides here. I thought I'll talk about the sciences here. So upper functions, functions of the upper airway, the nose: humidify, warm the filtered inspired air, trap particles or particulates. There are local defense mechanisms here, just the same as the lower airways. There's inflammatory cells here. There's resident immune cells and resident mast cells, which can play into allergic rhinitis. It's involved in olfaction and taste. The one structure that I didn't talk about, the sinuses. There's 5 pairs of them. Frontal sinus, doesn't show them all here. The big one here is the maxillary sinus. The ethmoids are the small ones here. What's the function of the sinuses? They're just these holes in the bone, and they're connected to the nasal cavity by one narrow opening. And so they drain into the cavity. They have a mucus and submucosal structure similar to the nose. So they produce mucus, and the mucus drains into the nose and then gets moved back to the nasopharynx. What's the function of the sinuses? Lots of theories. I'm not sure people really know what the functions of the sinuses are. They can help regulate intranasal pressure. Obviously, they can. I mean, if this was solid bone, it'd be real heavy. So they can lighten the weight. There's a theory that they help with resonance during phonation. They can absorb shock. Clearly, facial growth is a problem if it's solid bone. So they can help, with facial growth. But there are problems with the sinuses as well as with the rest of the nose. Narrow passageways, so fairly easily obstructed. The blood sinusoids, they can dilate, cause nasal congestion. It's the nose is the site of many of the common viruses that cause the common cold. So rhinovirus, coronavirus infections. It's the site of allergic rhinitis. Sinus problems. Real small opening, it can get blocked very easily. And when the opening of the sinuses does get blocked, then a couple of things can happen. If you've got bacteria in there, then you can get a bacterial infection. So you can get a sinusitis. If the opening is blocked, then this growth of bacteria, increased mucus, increases pressure and can cause pain. If it gets blocked off, and there's nothing in there, then, well, you can absorb the air that's in there and create a vacuum. Again, that can be painful. So either way, blocking off this opening of the sinus can lead to pain because either you absorb the air and get a vacuum, or you've got a bacterial infection in there. And sinusitis, bacterial infections in the sinuses are not easy to get rid of. Because of the axis, and you can't give a topical, and then systemically, it's not that easy to get rid of these infections. Okay. Any questions on the nose? Okay. You don't have this slide. It's not that important, but it's just to show. We're going to talk about the conducting airways. Mentioned them before. Conducting airways down to the respiratory airways. So trachea and bronchi. The airways are in white here, and on this side, this is an ink injection. You can see the pulmonary circulation. And so you can see the pulmonary artery blood flow in blue and the pulmonary venous blood flow after it's been through the the alveoli and picked up the oxygen in red. And it just gives an idea of the branching that you see of these airways. And when you go through 23 branches, 2 to the 23, that's a lot of airways there. Okay. So I think some of this is review from 371. We got 20 plus branches going from the trachea to the alveoli. So I think if it's 23 branches, that's something like about 8 million. If it's 22 branches, 4 million, obviously. So any more than 1 million of the alveoli. The conducting airways are what it says, conducting. They conduct the air. They take the air from the top of from the larynx and move it down to the alveoli. There's no gas exchange in the conducting airways. So this is considered dead space. It's an area that's been ventilated, but it's not involved in bringing in oxygen and getting rid of the CO2. The conducting airways, the larger ones are the trachea and the bronchi. So you start off with the trachea and you get bifurcations. And you probably get 5, 6 bifurcations of the bronchi. The trachea and bronchi have cartilage and smooth muscle. And the cartilage is C-shaped, so it's not a complete ring of cartilage. So it's a C-shaped piece of cartilage with some smooth muscle on the back. So the smooth muscle can contract and the airways can get a little bit smaller, but they can't close off because of this C-shaped piece of cartilage. Once you get past the bronchi, you get to the bronchioles and some different structural features here. There is no cartilage. And so these airways, and there's lots of smooth muscle. So these airways can close off because there's no cartilage to hold them open and there's lots of smooth muscle to constrict them. In bronchial asthma, the bronchioles are the major site of airway obstruction. Mucus is involved in asthma and is part of the airway obstruction in asthma. It's much more important in COPD. So COPD can get obstructed in the bronchi because of the large amounts of mucus. But in asthma, almost exclusively the obstruction is in the bronchioles. Once you get past the bronchioles, you get to the respiratory airways where there is gas exchange. You'll see some bronchioles referred to as respiratory bronchioles. Don't worry about those. The major area of gas exchange is the alveoli. So trachea and bronchi coming down to the non-respiratory bronchioles, respiratory bronchioles, don't worry about them, and then the alveoli, which is the major site of the gas exchange. Again, I think we saw this slide in 371. So this is a bronchus. Could be a trachea, but it's a bronchus. And the dark area here is the cartilage. So you see it's C-shaped, and there's an area here where there's smooth muscle. Come down to a bronchiole, no cartilage, lots of smooth muscle around it here. And we'll talk about the mucosal structure a bit later. And then you come down to the alveoli, and you see there, like these grape-like structures. So there's a duct coming in, and then it sort of expands into these, I say, grape-like structures, which are the alveoli, which is the major site of the gas exchange. bronchioles, we're going to talk a lot about these. They've got some different important features. No cartilage, so they can collapse. The anatomy is structured so that the bronchioles are connected to the alveoli and the interstitium in such a way that when you breathe in, it opens up the bronchioles. And when you breathe out, it closes the bronchioles. So they get smaller during expiration. You know, at low lung volumes, if you breathe out far enough, then you can start collapsing bronchioles. They can close off completely. And this traps gas behind them, gas that you cannot breathe out. We talked about this before. This is the residual volume. This volume, because of thickening of the bronchiolar walls, because of mucus, because of inflammatory responses, these bronchioles can close off at higher lung volumes. They can close off sooner in airway diseases. And so the residual volume in asthma, COPD goes up because these bronchioles are closing earlier during expiration. If you take a cross section through the mucosa, submucosa, basement membrane, all of that, trachea and bronchi, bronchioles, and the alveoli. So this is the epithelial layer in the trachea and bronchioles. There are mucus cells here and ciliated cells. And the ciliated cells, they have these cilia on them. And the goal of the cilia is they all beat in coordination and they move the mucus up the airways to the nasopharynx where you can swallow it or spit it out, whatever you want to do with it. If you look below the basement membrane, what you see in the trachea and bronchi are these submucosal glands. So these are also producing mucus, and these are the major sites of mucus production. So the major site of mucus production is trachea and bronchi. You do get mucus production, but just from the epithelial mucus cells in the bronchioles. Cartilage here, no cartilage here, but lots of smooth muscle here as well. And then the alveoli, we're going to talk about that separately, but you know, no cartilage, no mucus production, but there are other specialized cells in the alveoli. Okay. So if you look at the mucosa of the conducting airways, so trachea, bronchi, bronchioles, the mucosa, it's got ciliated cells, it's got secretory cells. Some of them are shaped like wine glasses. So they're fat at the top where all the mucus granules are and then thin at the bottom. And they're called goblet cells. The mucus cells in the bronchioles used to be called Clara cells. They're now called club cells. And I'm not sure for not sure of the reason for the change in name, but a lot of these name changes are because the people that discovered them are found to be related to the Nazi Party and involved in potentially war crimes and things like that. So whether the guy, Clara, or gal, I'm not sure, discovered these cells, did that, but they're now called club cells. These are the secretory cells in the bronchioles. And this is the mucosa. They sit on a basement membrane. Below the basement membrane, in the submucosa, this is where you've got the blood vessels, the mucus glands in the trachea and bronchi, the cartilage in the trachea and bronchi, and the smooth muscle, trachea, bronchi, and the bronchioles. Giancarlo. No. Do they? Actually, it's a good question. I say no pretty quickly, but that may not be true. No, no, they probably do regenerate. I don't think that. Certainly, you can get major loss of ciliated cells in COPD. And that's one of the problems. You lose the ciliated cells, you produce a lot of mucus, so the only way you can get rid of it is by coughing. But I think ciliated cells probably can regenerate. But just as I think in COPD, you're losing them faster than you can regenerate them. Yeah. Okay. The other cells that are around here, there are inflammatory cells and immunologic cells, immune cells, both in the mucosa, submucosa. Mast cells. Mast cells are central to allergic rhinitis, to the initiation of the asthmatic response in most people. There's T cells, resident macrophages, eosinophils, neutrophils, basophils. They're all around here. Basophils are simply, mast cells are tissue basophils. Basophils are in the blood, mast cells are in the tissue. And then the structural changes, there are structural changes in mucosa, submucosa, in asthma, COPD, and we'll talk about those later. Mucus is important to think about because it does have some important functions. Trap disabled inhaled particles. It's mainly water, but it's fairly viscous, and its physical chemical properties, its viscous properties are determined by the glycoproteins that it contains. And they're cleared from the airways under normal conditions by ciliary activity, but under abnormal disease conditions or conditions where there's some hypersecretion, then coughing comes into play. What else is in mucus? Well, there's antimicrobial molecules produced, defensins, there's immunoglobulins, there's secretory IgA here and IgG, and there's various enzymes, proteases, endopeptidases, and antioxidants. So, mucus is mainly water, glycoproteins, but it contains other things as well that help, protect the airways. In inflammatory conditions, there's upregulation of production of ROS and of reactive nitrogen species as well. And we'll talk more about these when we talk about mainly COPD. And changes in airway mucus. Mucus is protective, but there are changes, and this can play into the pathology of some of the diseases. Okay. And I didn't give you this slide because you don't need it, but it's just to show you some of the, the structures. This is a section through the nasal mucosa here, submucosa, showing the blood sinusoids and then the bone behind it. This is the one I've showed you on the trachea. This is an electron micrograph of goblet cells in the tracheal bronchus. So you see the ciliated cells here. These are the secretory cells. So, they're very bulbous, got a very thin bottom. So goblet cells. Scanning EM, the ciliated cells are in patches. So it's not a complete blanket of ciliated cells, and these patches move the mucus from patch to patch, but it's coordinated, so they do move it all in one direction. So these cells in between here, they would be, the secretory cells as well, and this is just a bit of a blow up. This is a picture of a diagram of a submucosal gland, and so it's a series of branches, and secretory cells are, all along here. So these are the major mucus-producing structures in the airways. Okay. Any questions on the conducting airways? Okay. So those are the ones that get the air down into the alveoli and out of the alveoli. This is the alveolar structure. So there's pulmonary capillaries one side, and then there's the air coming in the other side, and it's a very thin membrane. So this helps optimize gas exchange between the blood and the alveoli. There are 5 layers. Going from the air to the blood, you've got the alveolar epithelium sitting on a basement membrane. There's an interstitium, which is fairly thin, another basement membrane, and then the pulmonary capillaries. So you get the capillary endothelium. The cells in the alveoli, there's two major cells plus resident macrophages. So the type 1 cells are the prime, they call them the primary lining cells. These cover 95% of the surface area of the alveoli. They're very thin, they're very flat, they're very thin. The other type of cells are the type 2 cells. So these only cover the remaining 5% of the surface, but it's about 60% of the cells. So a lot more alveolar type 2 cells. These are the ones that produce surfactant. So the lining cells, flat and thin, most of the surface area. The alveolar type 2 cells producing the surfactant, not flat and thin, they're fat and granular, produce surfactants. In the interstitium here, you have, there's fibroblasts in here, but there's also, this is where the elastic fibers are. And this is what gives the lung its elasticity. We'll talk a bit more about that. And there are resident macrophages down here. So these scavenge particles that do get down, and particles, bacteria that do get down into the alveoli. What is surfactant made of? It's mainly a phospholipid. And it's secreted onto the alveolar surface. It forms this monomolecular film on the alveolar surface. And the fatty acids face out towards the lumen. This will be a fill-in question. Okay. It is 90% dipalmitoyl phosphatidylcholine, or DPPC. Okay, that's surfactant, 90% of it, and 10% it's other proteins. What's that?
The spelling count.
Absolutely. What's the goal of surfactant? It helps reduce the surface tension in the alveoli, so they are easier to expand. It stabilizes them, and it helps hold them open at the end of expiration. It increases lung compliance, so it's expandability. It makes the lungs easier to expand, which is the opposite of elasticity. The elasticity wants to collapse the lungs. So the decreases surface tension, holds them open, makes them easier to open, and it also, they're hydrophobic, and so it reduces fluid accumulation in the alveoli, which you certainly don't want. So, so three main functions for the surfactant. It's got 4 proteins associated with it, A, B, C, and D. They've got sort of immunologic functions. They're part of the innate immune system, and they just help they facilitate the effects of the surfactant. They help it form this monomolecular film and have its effects. So these proteins have important functions in in the immune system, but also facilitating the effects of the surfactant. Surfactant begins at week 25 of fetal development. Functional levels at 32 weeks. So premature babies who are born before 32 weeks of gestation do not have sufficient levels of surfactant. And this causes something called atelectasis, which is collapse of the alveoli. To help try and correct this, there is artificial surfactant therapy available for these infants, and this is put directly into the airways to try and help expand or try and keep the alveoli open until they've got enough of their own levels of the surfactant to do so. The other problem in infant respiratory distress syndrome, and this is something that goes back to the kidney. In utero, the airways are fluid filled, and at birth you need to get rid of that fluid out of the alveoli. This is done through sodium channels, ENaC. Okay, Remember those? Where are those in the kidney?
Collecting
Collecting duct. Great. Okay. So you have enacs here as well. Fluid filled because of chloride secretion at birth, rapid shift to sodium reabsorption via these enac channels to remove the fluid from the alveoli. In premature infants, they don't have completely developed enacs. And so they have problems with fluid in the alveoli and fluid retention in the alveoli. A couple of problems going on here in infant respiratory distress syndrome. The one really pertinent to what we're talking about is this problem with surfactant. Okay, any questions? Okay, I think we've run out of time for today, so we'll pick this up tomorrow.